Good morning, everyone. Before I begin, let me express my gratitude. It's indeed a pleasure and an honor to be here among eminent faculties. Special thanks to Dr. Mahesh sir for this wonderful opportunity. So what does actually specular microscope do? It helps us to evaluate the structure and the function of the innermost hexagonal layer of the corneal endothelium, that is, of the cornea. So how can we assess this? This can be assessed in two ways clinically, that is with a slit lamp biomicroscope, that is a specular view, or by using an instrument known as specular microscope. So all this actually started in 1968 by David Morris, when he actually designed the first specular microscope, and this is how it looked like. Yes, it was quite big and enormous, but that was a great concept. And it was finally in 1975 when Born and Kaufman actually designed the specular microscope as we see it today. So it helps us to assess the risk of intraocular surgery, to establish a diagnosis, and to decide on treatment. So what all actually are we assessing in a specular microscope? It helps us to assess a qualitative and quantitative assessment of the corneal endothelium. It tells us which are the abnormal endothelial cell structures, helps us to assess the grade of the endothelium. We can assess the cell size, presence of any polymegathism or pleomorphism, or for the cell perimeter and the average cell side length. In grading the endothelium, this actually looks at the cell conformation, boundaries, the intersections, and for the presence of any acellular structures. So when we talk about the optics of specular microscope, first what we should know is when light is actually striking on a surface, it may get reflected, transmitted, or may get absorbed. Or a combination of all these three can also occur. Now all this is depending upon the wavelength of the light, the relative transparency of the medium through which the light is passing or below the surface, and the relative refractive indices on each sides of the surface. So the actual principle of specular microscope is specular reflection, wherein the angle of reflection is equal to the angle of incidence. And we should also know that when light is striking on an irregular surface, it can get diffusely reflected. So as far as a transparent cornea is concerned, a light striking on the epithelial surface gets transmitted. In the stroma, some are getting absorbed or scattered because of cellular organelles. So when you have a corneal edema, the light is actually getting scattered, and that results in a hazy cornea. So as far as the corneal endothelium is concerned, in the endothelial aqueous humor interface, there is a big difference in their refractive indices, and some amount of light, that is around 0.022% of the light, is getting reflected of the corneal endothelial image. And this is the actual image that is taken up by or captured by the objective lens of the specular microscope. So when we are looking back at the principle of specular reflection, we know that the angle of incidence is equal to the angle of reflected light. To explain this in a better way, I would like to bring in an example of the reflection of a mountain or a tree that falls on a still river surface. And let's imagine that we are actually looking at the image on the still river surface. So here, the mountain or the tree is the endothelium. The interface on which the image is actually formed is the endothelial aqueous interface. That is the 0.022% area. And the objective lens of the specular microscope is the retina of the person or the observer. There is actually a definition for a wide zone and a thin zone, or a narrow zone. So when it's a wide slit, we only get 3 zones. But when we actually look at it through a narrow slit, we actually get 4 zones, which can actually be classified as zone 1, 2, 3 and 4. That is formed by the epithelium, stroma, endothelium and the aqueous. And it is that the interface between endothelium and aqueous humor that is of importance. Now, if this is a normal endothelial cell density, then this is a decreased endothelial cell density. And here we are actually looking at the morphology of the corneal endothelium. Here we should also be knowing about polymegathism and also a bit about pleomorphism. So in the normal endothelial cell density, we know it's around 3500 and up to 2500 is accepted, but all these cells are hexagonal, regular and uniform. In pleomorphism, we know the other terminology is polymorphism, and here we are actually dealing with the shape and the number of sides for each cells, which may vary from 4, 6, 5. Normally it is actually having 6 sides. In polymegathism, we are actually dealing with rosettes, and this is with regard to the cell size, and this can actually be graded at mild, moderate and severe. So when we are actually looking at the analysis of specular microscope, what we should know is there is something known as a fixed frame analysis, in which the frame that is used for analysis is fixed, and we actually count the number of endothelial cells touching on 2 sides of the frame, and we neglect the endothelium touching on the other 2 sides. Now this number of cells is divided by the area of the frame, that is around 0.01 mm square, multiplied by 100 in the numerator, and the denominator will give you the endothelial cell count. Now talking about a variable frame analysis, here what's actually happening is we are demarcating the normal irregularly shaped endothelial cells, and when we count the number of endothelial cells within that frame, then we divide it by the area that we have used to mark, and we are multiplying by 200 in the numerator and denominator, and here we are getting the number of cells. So what are the actual indications of a specular microscope? It is, as we all know, starting with Fuchs endothelial dystrophy, contact lens endotheliopathy, some assessments to be done before cataract surgery, something known as posterior polymorphous endothelial dystrophy, and an ICE syndrome is also existing. Before cataract surgery, we have to do a specular microscope when there is a history of previous trauma, there has been a history of pseudoexfoliation, recurrent uveitis, when there is a corneal edema seen in the contralateral eye after cataract surgery, or if we have an eye that has undergone a PKP with a cataract that has to be operated. Now, postgraduate, these are all the clinical indications of a specular microscope. Why am I saying these are the clinical indications? Because there has to be something else. That is then experimental indications of a specular microscope. So here we are actually assessing the endothelial count of a donor cornea. So this is an experimental indication, and mind you, it's an entirely different specular microscope known as experimental specular microscope, in which the donor cornea is taken, stored in a chamber and kept on a microscopic stage. Well, how do you interpret a printout of a specular microscope? This is actually how a printout of a specular microscope actually looks like. We have a cell density given, there is a standard deviation, there is a coefficient of variance, and there is hexagonality mentioned as 6A. There is also thickness of the cornea given. So there is number of cells in the marked frames that we have taken in the analysis part. Then we have to assess the cell density being mentioned, that is the density of cells within the frame. More important is the assessment of coefficient of variance. That is actually talking about pleomorphism, which is actually the physiological stress faced by the corneal endothelial cells. We also assess the hexagonality, that is percentage of cells which has 6 sides, which is actually expressed in percentage, and which along with the coefficient of variance will give us a complete idea about the morphometric parameters involved. And finally we have histogram, that is the number of cells with regard to the area occupied by the cells. So now, how does the actual normal endothelial printout looks like? This is how it actually looks like. There is a normal endothelium. And this is how a printout of a post-cataract endothelial decompensation would look like. There is decreased number of cells, there is high pleomorphism and coefficient of variance. Now this is how an endothelial would appear in a contact lens endotheliopathy, in which certain areas have stressed endothelium and the others won't have so. The normal endothelial cell count usually. Now this is a printout with a lot of guttae in the specular microscopic view that tells us this is none other than Fuchs endothelial dystrophy, which are actually excrescences produced. And finally, this is our Chandler syndrome, in which there is a total mishap of the hexagonal appearance of the corneal endothelium. So now this is how a specular microscope is actually taken. The cornea is focused, a snapshot is taken, that is giving us the endothelium. Then we take a fixed frame analysis. Then we count the number of endothelium touching two sides of the frame. So with regard to cell density, cells per millimeter square, 3500 cells are the norm. Up to 2500 is taken. Coefficient of variance up to 30 is fine. Anything more is telling us it is undergoing stress. Hexagonality is ideally it should be 100, but then up to 50 can be taken up. Less than that means it's a damaged decompensated cornea. So this is a case scenario in which one eye is having corneal edema. There is posterior chamber IOL is present in the right eye. Now there is a left eye that has to undergo a cataract surgery. So the question is, how is the specular printout? Now this is how the specular of the left eye is looking like. We know that the cell count is 955, which is very low, and there is a coefficient of variance that is towards across the border, that is 30, and reaching almost 40. That means there is some stress undergoing, and the hexagonality is around 44, which tells us it is well below 50%. So now we have a bad state of cornea here. So here, if it's cortical cataract, we actually look at the vision, and if there is a dire need from the patient side to undergo the surgery, then we have to make sure we are using Viscoat and all the precautionary measures for a minimal stress on the corneal endothelium. So this is the next case in which we can see there is a mild loss of corneal transparency, there are pigment granules on the corneal endothelium, and there is a clinically significant corneal edema, and this is how the specular microscope looks like. We can very well see that there are a lot of guttae in this printout, and there is a very low corneal endothelial cell density. There is the coefficient of variance doesn't seem to be in a danger, but the hexagonality seems to be very low, with an indication that is a Paki is higher of 612, which tells us there is a stromal edema. So this has to be Fuchs endothelial dystrophy. The next case, we can see that there is adequate cell count, but the problem is the coefficient of variance has reached at 40, and the hexagonalities also seem to be very low. That tells us whatever cells are present are under big stress. So this has to be a contact lens endotheliopathy. Now this is again a case of corneal guttae. That means this is actually Fuchs endothelial dystrophy you are actually looking at. So with that, I thank my mentors, Dr. Srinivas K. Rao for being, and Dr. Swatik for being a wonderful clinician, wonderful surgeon, and all the more wonderful teacher to me. Thank you, sirs, and thank you all for your patient listening.